Okay, good afternoon, ladies and gentlemen. Thank you, Dr. Sandhya, for this opportunity. And I'll be talking on wound-related issues in phacoemulsification. No financial interest in this. And in a phacoemulsification clear corneal incision, this looks as simple as this. You know, you just support. I just usually support the globe and then make a single plane entry. That's it. So nothing can go wrong actually. Basically, if you do it well. But then first it will start with the keratome itself. If the globe is turning so far down like this, it's a blunt keratome. It can cause DM stripping, it can cause irregular entries, it can suddenly get into the anterior chamber. So all these, when I started, people started coming. So they were waiting for me to start to come. That's why. So when I find this kind of a keratome, to begin with itself, if it doesn't move in smooth, I just drop that keratome and then get another one. Don't try to struggle with keratomes. And when, can you just, where is the mouse? Yeah. So these are marked keratomes. And you see the second hand here, stabilizing the globe. Usually I do it like this, either with the McPherson to close the incision and stabilize, or with nowadays with the 23 gauge MVR which I use, which goes into the anterior chamber, and it plugs the paracentesis. It holds the eye in position, and then I can create a clean wound. So these, I'm telling all these to prevent all the problems which you can have. It's better to prevent an incision problem, because till the end it will have a problem. So this is the two plane incision which I like in some cases, but mostly one plane incision will also do. And a single plane incision, generally once I am inside, I just cut the inner lip 0.25 millimeters, as you can see. It increases the space for maneuverability of your phacoprobe. So it makes you feel a little better. And the outer is exactly 2.4, so it doesn't leak. And at the end, hydration. I am very insistent on hydrating well and closing the wounds and seeing to it that it is closed on the table on pressure, because the patient is going to blink just after the case, and if you just leave it open, it can always leak, and then it can suck back fluid from the fornixes, and then it can cause unnecessary ingress of bacteria or whatever. So I just confirm it as dry it and make sure it doesn't leak spontaneously, and also pressure from a different location to see that it's not leaking. So this is how I close my incisions on table every case. So this is one case where I found a diamond blade. I was excited to use the diamond blade, and I just used it. It looked okay, but then it was looking little larger. I thought I'll go ahead with this, but see, it is so large an incision that iris just keeps coming into the incision. So the pupil will go down, you will have iris chafing, you will have burning of the iris, all those things, and it will be a messy surgery. So do not make sure what your company person is suggesting for their sleeve, and use that keratome. So 2.2 I use nowadays. I use a 2.4 because see here it's almost 4 millimeter. So a 2.8 sleeve is too loose in that, and it will be too messy. So either put a suture and do, or abandon this. Just abandon this and go to a different location and create a 2.2. You can. This will just like that close. So don't use abnormal looking keratomes which you are not used to. This is the one in which, see, happily we'll be phacoing, but at the end of the day, when you take it out, you will see something like this. If you had been causing, I'll come to that. This is a phaco burn. It's a small burn. Still, it can cause difficulty in closing the wound. It can cause astigmatism. So if it is not closing, definitely put sutures till you find that it has closed completely. This is another one. There are two reasons for making an anterior entry. One is a blunt keratome. So if you keep on going, it will not go in, and finally you will enter. This is almost 3 millimeters into the clear cornea. So every maneuver after that will cause distortion of the incision, and you won't be able to see things properly, and access the whatever you want to access will be difficult. Second thing is learners hesitant to press down. So if you keep on going, suggesting that you will now enter, okay, go a little more. So you'll keep on going, and finally you'll end up going too far anterior. So at the point where you want to enter, dip down, press, go in, and then straighten out the tip, and then complete the entry. So this is how I suggest to close. We can put radial suture also because it's a small incision, but if you have a burn and other things, it's always better to do a horizontal suturing. Go along the floor of the incision, come out, and then on top of the superior part of the upper lip, and then in between the upper and lower lip, bring it out, and then make knots. Horizontal will always close, approximate the incision better than radial sutures, but radial is easier to make, see, and do also. But here, see, this is a paracentesis. Still, it has been manipulated so much that a tight Simcoe was put in through that and tilted, turned, and all those. So even if that does not close, suture that. And you can notice that I'm suturing once, and at the end of that suture, if it still doesn't stop leaking, I will put another suture. There is no harm putting in a suture. We don't promise patient that there will be nothing, no suture, nothing. No. At the end of the day, if the vision is good, you can always tell on the skin part there is a small suture. We can just take it off on the slit lamp itself. You can do on a later date. So this is another dreaded problem which can happen. This is an SICS wound, but still, when you manipulate some incisions in phaco also, you can get this kind of a DM stripping. So this DM stripping is a bad thing to have. Even last week, one of our trainees had it, and it was sometimes, mostly it is from the incision site. When you have people with very hazy looking cornea, some arcus, large arcus, old people, and crocodile shagreen and all those, their DMs are loose. There are people with the loose DM. Believe it or not, there are people with loose DM. So you hydrate it a little bit, suddenly you'll see a flap coming off. Or even with just entry of anything, there will be a small flap hanging. So be very careful when you're entering inside and manipulating this. And sometimes you get it along paracentesis or incisions through which you have injected viscoelastic. So viscoelastic or something goes in between, then it is very difficult to oppose it. You will have to have venting incisions and then place in C3F8 or something and iron it out for a long time. And then, because we had to bubble a case twice because there was visco in between the DM and the stroma. So coming last to the femto incisions, sometimes it is difficult to identify, but if you dry it and wait for some time, you will identify the epithelial cut area and identify that, and the depth has to be identified. And this instrument is crucial to have, not just the cyclodylus spatula or a Sinski. This has the different plane in which you can go down a bit and then identify the plane and go in. Sometimes it doesn't fully open, so don't struggle or push through. Sometimes you can detach a DM if you try to push it through uncut areas. So if it is definitely uncut, use your keratome to extend it to the adequate size. And sometimes, mostly when you do right eyes, you will see superior arcus like this, where femto cuts do not work. So in such a case, always use your blade to open it up. And here again, you can notice that this cut is too anterior into the clear cornea, the paracentesis. So this is so easy to open if cut well. So it just like that opens, but this one I would just abandon it and make a peripheral paracentesis and go ahead. Otherwise, it will be difficult to manipulate through these instruments. So these are some tips which I would like to offer for having less complications with the wound in phacoemulsification. Thank you very much. So I'm sorry that I have to go for another session immediately. So I can't take questions at the end. If you have questions right now, in 1 minute we can answer.
Thank you, sir, for that excellent talk. Sir, I want to ask one question, sir. If there is a DM tear at the clear corneal wound, before start of phaco, what strategy would you do, sir?
Such DM tears happen as small flaps. Small flaps. So small flaps, definitely you can watch and go in. I do not irrigate while going inside. That is one thing which I don't do. I irrigate and get the air out, but then I go in dry and make sure that I don't drag this along. Depress the posterior lip and go inside. And with each movement, don't retract the phaco probe too much, so that the irrigation comes very close to the incision site. And also don't retract the sleeve also too much. Don't expose it too much so that when you retract it. So don't disturb that area much if it is just a small flap. And especially in a good looking cornea, a healthy looking cornea. But if it is already a large flap, 2-3 millimeters, I would suggest better not to manipulate, because we cannot keep on looking at it. We say you have one eye on this, one eye on that, nothing like that. You will be looking only at the phaco tip only. This you cannot keep on looking. Otherwise, you have to change your thing and look at this and stop phaco. It's not possible. So if large one and vague looking ones, better abandon and make an incision next to it.
Your the point that some eyes are more prone for DM stripping. I totally agree with that. But then often we might overlook all that. And one question is, did you take that video just to show how the wound cornea gets distorted, where you made a slightly anterior entry? Why don't you do your access through the side port
This was done by a trainee.
training?
So actually, side port is also a definite option when you have this kind of a problem. Go through a side port. But after that, again, you have to go in with your hydrosection. You have to use the main probe. So anything you use, you'll have to tilt. Go through the cornea and tilt down. You'll get striae and the globe will turn away and all those. So this was actually done by a trainee. Later on, it had to be it was converted into an SICA, so that's why we didn't bother much. But we had to tell them that this is not the way to do, because they were straining to enter, waiting, keeping on going forward, finally enter, and finally enter. You enter 3 millimeters anterior. So that's what happens. Okay, thank you.